Okay, guys. So this is going to be uh, the sixth session on this AI part. So this is uh, more towards a bit like what Niven said, practical aspects of AI, when to use it, when not to use it. Is it really justified? Is it mostly hype? And how do we connect it back to clinical FP and research? So it's a sort of a tying up of the last five sessions. So the first thing is, if you look at it in clinical epi, we are always looking at primary outcomes, secondary outcomes like the trial you just did. But if you look at AI, they're not looking at that. Large volume you see. So the first thing is they don't have the hypothesis. And you research like the study hypothesis was this automated messages will improve patient compliance and drugs, and there will be less not taking of drugs. But in AI, generally in huge AI research, there's no hypothesis. They're looking for patterns in people's behavior. The second thing is when you look at statistical tests, you call them parametric tests, non-parametric tests, t-test, chi-square test, the logistic regression, linear regression. If you look at this techniques used in AI, you get used to words like random forest, neural network, XGBoost. So the words are slightly different. Statistical analysis, like if we were discussing right now, why did they do Bonferroni and why did they do interim, why did the sample size increase? So the statistical plan we make is whatever we get, we follow through to the end. So we can't take the statistical analysis halfway through. It's a fixed statistical plan. Whereas if you look at artificial intelligence, is more prone to instability and changes along the way. So there can be changes like that. Conventional statistical methods are usually done in cross-sectional, cohort, RCT, case control studies. The implication is only in that part of clinical MP. But increasingly in medicine, we have electronic health records. So look at CMC's electronic health records. It's huge, like it's humongous. Data, the ECG, the X-ray, so many different kinds of images and other things are there. So the types of applications for AI has become huge in healthcare. Then the purpose of this, of usual statistical methods. So if you look at naval study, we just prove it with the statistical techniques. But if you look at application of AI, they just get massive amounts of data and just making some interpretation of it. There's no concept of having a hypothesis and rejecting a null hypothesis. Now, Niven concluded we must look at external qualities. Study was done somewhere in US. We need to do a study in India and see whether it's pragmatical. So that reproducibility is when we repeat another RPT here and see whether it's done. The problem for AI is what they do is they get a large volume of data, then they divide it into 2/3 and 1/3 or something usually. They'll develop the AI model on 2/3 and see if it works well on 1/3. There's an internal generalization. Then they must get a new data set. Let us say we develop an AI model in CMC. We must go and try it out on some other medical college, St. John's Medical College database. That's how generalizability is done in AI or reproducibility. Barriers. Now, during the trial, we can't go on looking at the data and seeing. That's not a barrier really, but you want to have some planned interim analysis, which they seem to have done in your trial. Whereas, if you look at AI, they are doing some AI methodology. Nobody knows what's happening inside that AI methodology. You can't ask even the AI expert, explain to me what is that method, like how it exactly happened. Very difficult to get that explanation. Interpreting, we have all become expert now in interpreting relative race, constitutional, routine investigation. Whereas if you ask, like I said, this is called the black box. How do you think that this is going to work? Neural network work. We can't explain that because it's got the computer has so many things inside which nobody. It's called the black box. Equity is the last one. So that is where we come to actually title very nicely to your trial. Pragmatic trials are all about whether it will help the patient. It may some intervention may help the patient, but he may be financially worse off, or the system may actually suffer by that intervention. So that is a we can look measure it. We can do things like the PRECISE trial or other equity measurements. Whereas we have to be very careful about this equity in AI. The AI can subtly actually if we allocate, there is a company like SAMPU, we have started out the first class. AI, well, they found in US was allocating more resources to predominantly white populations because the health outcomes were better there. So the AI's job was to make health outcomes better. So instead of wasting money on poorer that is allocate money to more richer white neighborhoods because the health outcomes will improve better. So that it is not doing it intentionally, but it happens. Actually, in fact, we need to spend more money on color areas in a foreign country. So that it happens subtly because nobody's looking and seeing. And before you realize it, the AI can make decisions for you which can be unequitable. So I've talked about that mitigation strategies. So what we need to do for this black box problem is that we need to have some quality control. Okay, now that this chat box said that this is what you should do. The chat bot said that this is psychiatry. Now many psychiatrists in the US are using chat bots, so you can log in and you can talk to a chat bot how you're feeling and it will tell you what to do. But somebody has to go and check, hey, is the advice being given once in a while correct? This is giving something completely wrong. So we need to have somebody who's going to do some quality control. Information leakage is a slightly different concept. Suppose I have a large volume of data and I develop the model on one part and validate on another part. But actually, it's the same data there. Suppose I take medicine department data and divide it two-thirds, one-third. It's an artificial division. The one-third is going to look very similar to this two-third. Second thing, we should make sure that the data which was used in the development of the AI should not leak into the validation part of the AI. So that's called data leakage or information leakage. The third thing is overfitting. Overfitting, in the first class I said, you put so much data into that and so many variables to try to map every dot in the process. That's called overfitting. So the only way to overcome that is to have a validation cohort and see, oh, yeah, I've done some overfitting. So be careful of overfitting. Implementation and in practice, you must think about this AI model. Let's say, for example, we're going to use chatbots for improving drug delivery in CMC. How will that integrate with our workstation? How will we scale it up to Mission Hospital? You're asking the question. So it's not simple, AI works very well, AI chatbot very good. How is it going to be scaling up and how will it work in real world? So now let us say that bias of unmonitored data. Let us say an insurance company gets hand of CMC's AI data. Oh, the following people have got Modi gene. They're going to develop diabetes in future. Let us increase their insurance premium, or let us refuse insurance. Or this person has a family history of cancer. Therefore, his insurance premium goes up. And that's not because his now database is completely AI. Most AI databases need more than 10,000, 100,000 samples. So now in US, we find that those are only available with large pharma companies, large industry. So we need to be able to working with the industry to do this part. So that's some area to be a bit careful about. Just as an aside, now all of us have got a health ID. You know the name of that health ID? Every Indian, ABBA ID. So suppose now they say let us develop AI using ABBA AI. So everybody in India, all your data is immediately available to somebody to develop AI. Can easily be misused. One person was telling Dr. Vignesh and me, I don't know whether I should mention it. He said, who knows, one day from now I need a kidney transplant. Identify a young healthy man of same blood group donor somewhere. And mysteriously he has met with a road traffic accident and his kidney is now available. I mean, it sounds a bit far-fetched and fictitious, but with an ABBA ID with everybody knowing everybody and our system, I'm not saying that this is going to happen. I'm just saying that this is a technical thing. I mean, it's not a false story. It's just people believe this to be happening already. So this is just something to keep in mind. Okay, little bit different. Drug discovery with an AI. So I told you I'm going to wrap up the whole thing, putting everything together. So everybody says faster, like Olympics, no faster, higher. So that goal of drug discovery in AI is faster, cheaper, more effective. So you have a large database of chemicals. You can extract chemicals from that. And then you say, okay, I want this chemical for this property. And you can say for this cellular effect, I want it to reduce IL-10, for example, today morning stop. I need a drug for IL-10 increase. That will help reduce drug typhus mortality. So because we have these large data sets, we can do predictive synthesis. I can predict how to make a molecule. Biology is better. I can model pharmacokinetics, pharmacodynamics. Polypharmacy is there. If I give 4 drugs from diabetes, hypertension, cholesterol, and for heart disease, how will they interact with each other? The AI can help us to predict that. And if I make a new molecule, if I design a new molecule, what possible effect will it actually have on all of these? So this is a nice paper published by an Indian group, and it's looking at various aspects of artificial intelligence in health. But I just want to talk about drug discovery. The most important thing was not new drug discovery, but drug repurposing. Like for example, we all know that ivermectin or chloroquine. AI predicted it will be very useful in COVID. So everybody started taking it. It didn't work out in the end, but repurposing an old drug for a new condition. Then manufacturing. Hey, we are manufacturing this drug this way. Can I manufacture a better, cheaper, more effective way? Drug treatment optimization. Instead of giving this costly drug every month, maybe if I give the costly drug once in 3 months, it will have the same effect. Or if I can do something else, optimizing that, also very useful. And in new drug development. So the next slide, I'm just going to talk about this artificial intelligence and drug repurposing, because it makes me curious. There are 3 methods of drug repurposing: network, feature-based, and matrix-based. So this network is based on biological networks. If I increase IL-10, then inflammation comes down. So what drug can I use to increase IL-10? What biological effect it will have here and there? So it's understanding of deep biology and the biological networks, how the drug may work. So drug repurposing, one method is called network-based approach. The second one is called feature-based approach, where you have like this logistic regression, linear regression, k nearest neighbor, and you're trying to do something based on the features available, how to develop or repurpose a drug. The last one is called a matrix-based approach. So not very high on tech, but this is you develop a drug matrix and then you try to develop models based on matrix. Just to know that people are actively now trying all over the world. Let us do these 3 methods to repurpose drugs. The last one for drug is again, this article is a nice article. If anybody is interested, I've given the URL about drugs and AI. It's on pharmacovigilance. So if you have CMC, we have large data. Every day people are entering drug allergies, drug this, drug that. That's called pharmacovigilance. So we can see that, hey, these kind of people are the ones who are getting this drug allergy in CMC. Or these people with this genetic code are having this. So we can use pharmacovigilance using AI also. We can increase the detection of side effects or whatever problems are happening. So it's an interesting area in pharmacy and medicine or drug discovery in medicine. Now, critical appraisal. So the critical appraisal which Niven gave is a tool called Precis tool. And like that, there are many AI tools. So let me see if anybody can remember. Consort is for, let's ask the PGs. Don't worry. We don't know. Consort is for which kind of study design? RTT, case control. Excellent. So now if you're doing Janvi is not here. She did a critical appraisal of one arm of the RCT was an AI based tool. Even yours is technically an AI based, like one arm was chatbot based. So did they use Consort AI in their methodology? So Consort tool they would have used to develop the study. So now this Consort AI extension. So if you're using AI as a one arm of an RCT, Consort tool should be used, but if you use a Consort AI extension, so that's an important thing. The Consort AI working group. Now, one of it is developing models for the future, predicting the future. Who did that? You did that. So for that, it's called tripod checklist to develop a model. These five, for example, we say Apache score will predict. How do they develop that Apache score? They should have used a checklist which is called tripod checklist. But if you're using AI now, tripod AI extension. How do you do critical appraisal of developing a model? That critical appraisal is called probast. If you develop a model, how do you critically appraise the risk of bias in model development? Probast. So now there's probast AI extension. Then StarD diagnostic. And if you're going to use AI for the diagnostic methodology, there's a StarD AI. I've given the references for each of these. The last one I've given here is called Decide. Decide is for decision analysis. I think one of you did critical appraisal of decision analysis. It's not in the law. It's been a while since decision analysis. So for Decide AI is also there. Anyway, we all know this now, but this for the online audience as well later on. So this Consort checklist, all this is available in Equator network. So Consort, StarD, all these are freely available. And if you just click on extension, now all those AI extensions also are easily available. So that's an easy part to do that. So last week, Dr. Jayasidan was saying that how do we make sure this model which we develop is actually useful in practice? Millions of models are being developed only for publication. I mean, to be very pessimistic, actually nobody uses it. So in this paper, which is published in August, I think, of 2024, they say that less than 2% of AI models are actually used in any hospital or any clinical setting. So that means 98% of the models developed actually are just not being used by anybody. And this AI-based clinical decision support system, the only couple of places you can predict who will need IV fluid or vasopressin sepsis. So ICU sometimes use this is one of the few examples that you put all the data inside and then this patient probably requires fluid, or that person is going to require inotropium in the next few minutes, something like that. So I just wanted to highlight work by Dr. Vignesh to predict the outcome of sepsis. So we had medicine 2,500 patients with sepsis, and we want to know who will survive and who will not survive. So he did an analysis along with Dr. Jayasidan. And this paper has just been published, or is going to be published in the next issue of the Postgraduate Journal of Medicine. So this is looking at the outcome of sepsis and an algorithm. But we just developed a model. We are not validated it on new. How to see whether it will be useful or not. So we used stroke checklist because we developed a model. Observation study stroke. We used probast and we used tripod. At that time, there was no AI extension, but we used a reference. These two fellows, Moore and Stevens, were suggested what should be an AI model. So that's something to consider. But we should have actually used it. Now we should use the AI extension. So if you are developing a model, you do this what is called discrimination and calibration. One of you did a critical appraisal of prognostic models. ROC curve, you did diagnostic study ROC curve, that's called discrimination. And there's a separate curve called calibration. So whenever we do this model, so any of you are developing a model, you must use tripod AI and StarD AI. Then the next step is to try it in clinical practice. So next, I believe we should take all our sepsis patients and see what the doctor says, alive or dead, what the AI model says, and finally what actually happened. You can roll it out in real life and see what's going to happen. And if you for developing a protocol, it's called Spirit, a protocol for a study, consort AI and decide AI. So these are the tools to be used. So why is that only 2%? Why do most interventions or inventions never reach the light of day? So if you in our Mac workshop, there was a talk by one Dr. Christina from Marlena. She gave a talk from Australia, how to implement things. So this is called Proctor's implementation steps. I'm not going to take you through everyone. It's very self-explanation. What are they? Acceptability. Hey, is this AI tool acceptable? And I thought in psychiatry it won't be acceptable for a chat bot to be giving you counseling. But people are like, it's acceptable even in psychiatry. So in sepsis, why wouldn't the tool which predicts outcome be acceptable? Adoption. Now, if we have to go and log into a computer and so casualty and then enter 15 points of data, nobody will do. So it has to be adoptable. So it should be just from the workstation, data should come in, all the history physical, and it should automatically generate adoption. Appropriateness. Like many people, it is not appropriate for me. Like this telling in the time of COVID, I can't go to psychiatrist. So it was very appropriate if I have an online psychiatrist not willing to do online consult. It was appropriate to have a chatbot. The cost. The cost for CMC or any hospital in India to have a chest X-ray read by AI is how much? 40 rupees. Is that appropriate? Chest X-ray itself costs 50 rupees. Then to have the AI to read it is 40 rupees. So if you look at that, it sounds like 40 bucks is nothing for a chest X-ray. But in relation to the cost of the chest X-ray, actually all chest X-ray is supposed to come with a radiology report. Yeah, instead of that, you're paying 40 bucks for the AI. So you have to look at the cost carefully. What cost I'm really going to do. The next one is called feasibility. Okay, this AI works very well in CMC. But if we're going to roll it out to mission hospital, how are we going to roll out the AI in a mission hospital? For example, the same chest X-ray in India, they're doing chest X-rays in many rural hospitals, and they're doing this AI. You know the biggest problem? Internet access. You take a chest X-ray, just to be uploaded onto the AI server, it will read the AI and the report will come back. In the absence of if internet is there, no electricity. Electricity is there, no internet, or something else. So the whole problem is this kind of small things on feasibility. Fidelity. Now, I developed it for some particular way of being used. Is it going to be used in the same exact way? Or will people misuse it or use it in some slightly other way? Penetration is like if we can put the AI into CMC's clinical workstation, it takes history and physical, which we are typing, interprets it using some large language model as data. It adds on the lab data which we get. Then we don't have to do anything. It's integrated in our system. Automatically, the Apache score is calculated, or the AI sepsis is predicted, or the mean for fluid. So it's integrated easily. You don't have to do anything. Otherwise, you must take this data, load it into a separate computer, then the AI should have what to do. It is not integrated. Finally, sustainability. Now, suppose we have to spend 1 crore every year. It's not a sustainable model for us to develop. So, these are the questions which people are asking in various randomized control trials now. If you are going to use AI, don't just develop another model, answer these 6 questions of this Proctor. So, they are suggesting a new change in the way we develop models. Yeah, you develop whatever model you want. And you describe discrimination, calibration, ROC plot. Before you implement, you answer these 6 questions, acceptability to sustainability. Is it really going to answer all those questions? Then the next step is you assess the clinical utility. In real life, does it really make a difference to patients? So this is again, I told you today's session about rapid development. So we must think carefully about before we implement any new intervention. Yeah, I'll stop. Any questions now? We'll move on. Yes, someone is there. Questions so far? Anybody? Ah. Okay. Okay, so now I'm going to go through the steps. Suppose one of you want to do an AI project and you're interested. What are the steps to go through? So slowly. First, to understand the problem. What are you trying to solve? The same question I was telling them. What is the question we're trying to answer? There should be a clear question. For example, people are not taking drugs, medicines. They are missing many medicines. That's a worthwhile problem to solve. Because if they take it regularly, then they'll get better. That's a problem to solve. Do you really require AI to solve that problem? Or are you just trying to invent a place to put AI inside? Is the problem only in CMC or is a widespread problem? No, no. People not taking drugs, everybody is a wide world. It's not a niche problem. So, for example, okay, one unit is not prescribing drug A. AI is not going to change that automated drug delivery or reminder is not going to improve that. That's a local problem within our house because of differences in practice. So we should not imagine that AI will solve that problem. So people think AI will solve all problems. AI will not solve those kind of issues where people just have different practices of behavior. So be careful, is really AI going to do something? Second, quality of the data. GIGO stands for ego. Garbage in, garbage out. That means if you train the AI on useless data, the AI output will also be useless. So be very careful before somebody says, use this AI model. Hello, can you tell us something about the data on which this AI model was trained? What is the quality of that data? Nobody likes to ask these questions. So be careful of that. So because everything is biased, the AI can be biased because it was trained on wrong data. It's not wrong. AI was trained on a Western model of data where the practices, everything is different. And we're going to use that AI model in India blindly. It's not wrong for that situation where it's developed. It's wrong for us to blindly implement that model. So quality and other things could be different. Okay. Evaluating performance. Now remember I said there's a development model and a validation model. Development, I said that these 10 factors predict the outcome of success. In your own model, you look very nice. But in a fresh set of 20 patients, does it really work? That's called evaluation model. Development and validation. So the development in real life, what happens? Should we make the jump? Is a question. So in AI, we generally divide the model into a test set and a training set. Well, you train it on one and you test it on the second half of it. Then we do the performance, which is the ROC curve and other performance metrics. Sensitivity, specificity, ROC curve. Now, this is the gold standard used in UK, like gold coin, everybody measures against that. But the biggest benchmark is who? Ultimately, the clinician should be happy. Yes, this AI model is better than me. So you find that most of the models, even Apache score, which people are using in ICU, it only helps you to understand. Ultimately, a good clinician in ICU can make far better prediction of what's going to happen. And it can help you, but you must benchmark against a good clinician, experienced clinician. Don't say the ROC curve alone, sensitivity. No. Against an experienced clinician, how is that benchmarking? Okay. After that, you can try multi-site trials. Now we are saying that this AI model is been present was that in one place. What if there was a multi-center trial? 6 countries. Then we know, hey, it's working in India, it's working in Japan, working in South Africa. Why not? It's implementable across the whole thing. That's the next step of doing. Then there's something called dependencies. Let us use this. For example, we have an ophthalmoscope with AI. So this is what Dr. Vignesh and me thought. Once and two means everybody will be using now the AI-based ophthalmoscope and getting the reports. But in real life, we are still sitting somewhere in the beginning of this curve and we're trying to figure out how to get our way there. So what is that dependency? Cost. So we have to spend a lot of time explaining to admin why we should get this AI-based thing. Dependencies. Nobody wants our hospital data. We want our workstation to be getting a virus, hospital information system. So they're very, very wary of getting that system to marry and talk to our system. Are you very sure that there'll be nothing coming inside? Right. Our IT system may be slightly different from that IT system. So those are the problems which come inside. That ophthalmoscope image is sent to a cloud, reported by AI, and the AI report comes back to CMC. That means there's a issue also of confidentiality. Your retina image is being sent to some other server, it is read by somebody else and comes back down. So there's another problem with integrating this. So suppose that means now some external server has to talk to CMC's workstation. And we must download an external server report into our workstation. And then say, no, we don't want this to happen because it's a bit too risky for us. And patients will say, how come my image is also being stored on some other server? I gave you the permission for here. So that's also all. So this is what is called dependency. That's fantastic. Everywhere in India, people are using the same machine that we have. All health camps all over India, people are using the same machine. But they're not very worried about because the image goes directly to the patient's phone and along with the AI generated report. So patient is very happy. I'm getting my report immediately. No need for fundus dilatation. But to implement in a hospital-wide setting, suddenly the whole dependencies change. Looking beyond the model. So what is that? Trust. So now we say that when we went to the admin with that ophthalmoscope, who else is using in India? The developed Chennai Shankar Nirmal is using it. No. Finally, we found a Shell hospital. Community health department, community health wing is using it for all their community health programs. Oh, we're already using in CMC. Okay, then trust issue went off. There's always a trust. What is this strange new technology? What we are studying now in our workflow. So now we are still every day we're talking to chips. How to make it seamless. Nobody order of fundus examination. There should be a place they go, get it, image automatically uploaded along with report. That's seamless into our workflow. So for this, we had Dr. Vignesh had go sit with chips for 20 times, tell them what, when a patient comes, where will they go, how much it will pay, how it does it must go seamlessly instead of becoming an extra one hurdle. In the end of the day, just because we are looking at fundus, will the patient's diabetic retinopathy get better? Will doctors change their behavior? Oh, your diabetic retinopathy, I better control your sugar better. Will patients be more compliant with medicine? Will they go to see ophthalmologist more regularly after that? We don't know that. Whereas at least our diagnosis is better, but does it make any difference to the patient's outcome? That's the next step to start considering. So looking beyond the model. The last one is cost effective. And that's something that we need to also think, okay, we spent 10 lakhs on buying ophthalmoscope. Other than saying very like a new boy's toy, and we are happy with it. Did it really cost effective in the long run? Okay. Now moving on. Okay, any questions on that? It's a slightly different topic now. This is ethics. So now we all know from ethics because we have to take ethics class. One is called beneficence. What do you think beneficence means? Simply, what do you think? Do good. So this is the symbol for doing good, beneficence. So we must do good. Whenever possible, the AI system must do good, beneficence. Non-maleficent means don't do any harm. This is the world's first lawsuit against ChatGPT. Somebody went to court a case against ChatGPT, an AI engine, right? Because the AI engine said bad things about him. So if you Google ChatGPT, one mayor in Australia, the ChatGPT is a useless fellow. So this fellow mayor said, how can you say this? I'm suing ChatGPT. So in real life also the AI in healthcare should not do any harm. Non-maleficence. Autonomy. Now, will the AI tell me what to do or will give me will take my data without me knowing? Do we have autonomy over our other data? Do we have autonomy over our data? I don't want my ABBA data to be shared with AI. No. But do I have the right to say yes or no? So autonomy is a very important thing with AI because now people say, hey, I'm taking mountains of data. If I take 10 people's data, each pieces I must get information, consent signed. If I'm taking 1 lakh people's data, some people say, let us waive consent. Hello, where is the autonomy of the 1 lakh people? They say the typical story in UK. The AI people took UK NHS data to develop AI models. Now they got the data for free. Now they developed the model. Now they're charging NHS to use that model. You developed the data on my, you developed a model on my data. Now you're charging me for the model. So if you think carefully about this autonomy aspect. The last one is justice. Justice overall, like, this is going to do good for the society or do harm for the society. So we have to have a little bit of a thought about, well, what is this AI really going to do? And this is a picture from the Turing Institute, Alan Turing Institute in the UK about justice and AI. And there's a lady justice holding the. Oh. Now this is called, I mean, I like mnemonics. So this is called the firm model. So what does the firm model stand for? So it should do more benefit than harm. Basically, that's what it is. So what does firm stands for? Fair, useful, reliable AI model. I mean, it's a trick. But somebody asked about AI and ethics. That is remember firm. Fair, useful, reliable AI model. So before you deploy it in any country, before we use the AI part of it in CMC or in medicine to even the AI for ophthalmoscopy, is it fair for everybody? Is it useful for everybody? Is it a reliable index? Then we can say that we'll deploy this AI model in CMC. So that this is one of the first slides I presented on the first model. It's called the hype cycle. It's called the Gartner hype cycle. So we have new ophthalmoscope with AI. Expectation is very high. Then after some time, oh, this was a useless thing. Then after some time, for the sound. So just to replay, be careful of height. Second, populations might have changed, or it a model developed earlier. People might change their behavior. The AI model may not predict accurately what's going to happen now. So even the way data is generated. So suppose sometimes this is outbreaks, and people are not able to explain an outbreak. How come suddenly a outbreak increase or decrease? Then they look carefully and see that, oh, the outbreak appears to increase because one hospital's data was not being collected for the first 3 months. When that hospital data was added, suddenly the outbreak appears to jump. It is a data generation process change. Or in the beginning of the COVID pandemic, everybody had to be RT-PCR positive to be called. Midway through, there's not enough tests. So they said everybody with fever, cough, and breathing difficulty midway through the pandemic is called COVID. Suddenly, another spot is the pandemic. So the data generation, definitions all change. So to be careful about this, even when you're doing AI, especially doing AI, because nobody's looking at that data carefully to see what explains these changes in data. So I just wanted to tell you, this is from Dr. Vignesh's paper on AI and synthesis. If you know the ROC curve, the curve which is closer to this going up on the left and going down across the right, that's a better curve. So this was to differentiate people who died from sepsis versus those who don't die. So he did 4 or 5 models, RF, SVM, GNM, and a GBM and a stack SVM model. These are just some fancy words, different AI models, which we didn't get. And we found that the red one is the best. That is random forest model seem to work the best. So these are just some ways of looking at performance. So you must ask somebody performance. Now I just googled this about a month ago and I found that in EPIDEMIOLOGY, now there's an FDA approved tool for sepsis prediction. So I wanted to say, oh, how do they do? What is their tool? And as an Indian author also, so I was very pleased to see that, Bhargava. So remember I said you derive the model on one group and you implement the model on another group. And you test it out on another group. So just look at this. Remember I said ROC curve close to 1 is good. Okay. So this is the new score which that group developed, Bhargava and colleague. They called it sepsis immunoscore because they did some other markers. Derivation cohort is the first, they had a group of data where they derived it. The ROC curve was 0.85. It's not bad, closer to 0.91 is good. When they did an external validation on a new data set, what happens? It went down. But they published it. Despite that not being fantastic, they said, okay, this is acceptable to us. So always be careful, ask somebody, okay, to derive this model on one cohort, when you validate it on another cohort, what was your actual data? So now I'm going to share with you what we did in medicine 2. We took our sepsis data set and we divided it into 2. So what is our data? So I don't want you to look at the whole thing. The top half is the training data set. The bottom half is the testing data set. The same thing which I showed you earlier. Derivation and validation, external validation. Here they have derivation and internal validation. The full data set was divided into 2/3 and 1/3, derived on the 2/3 and checked out on the other 1/3. That's called internal validation. External validation is take a new at the hospital or a fresh set of data. In medicine 2, we derived it, and this is internal validation. We call it training and test. Let's look at just one of them. The one we can look at this last one. Just look at the let us just look at the sensitivity of the stack with SVM. Just some model. Sensitivity was 95% when we developed it. In the remainder 1/3 when we used it, it came down to 83%. This is just when we artificially divided the data into 2/3 and 1/3. In that itself, it is not doing so well. So we'll always ask people, hello, how did it work out in your own internal validation and in external validation? So coming back to the hype part of it, look at the biases. Now, I was very pleased to you guys. This is a qualitative, nice presentation, by the way. Meaning, AI can interpret data, but it can't give you the meaning of why people do or what people do. So people often look at AI to explain, understand some phenomenon. No. It give you the numbers and tell you what happened, but it won't explain you the meaning of what is happening. So don't look to AI to understand meaning. Meaning is when you look at the data, you understand people, you talk to people, you qualitative research, then you understand what happens. Right? Demand transparency. Now, if somebody asks us, like, can you share your data? We should be willing to share our data. Now, all modern publications will say, on reasonable request, I'll share the data. I will share the data. If you share the model that you use, the algorithm that you use, most people will not share the model or algorithm. Now, how can I know whether you did correctly or wrong? That's another step. Even all, let us say, randomized control studies, pharma funded trials, they will give the whole data to FDA. FDA sanction will reanalyze the data and see whether they get the same results. But in the non-industry academic places, they're a bit hesitant to share because why I want to write one more paper. Till the second paper is out, I don't want to share the data. So the sharing of data in AI is even more complex. I want to share a voluminous data and some model which I developed myself. I may not want to share that and be transparent. Okay, let me ask, what is black hat, white hat? Look at it. Not a medical term, I'm asking that. Anybody? Yes. Okay, this is from the, if you like spy movies, all this is the new. This is actually from spy movies, it's not from medicine. When you develop AI, can somebody come and cause trouble? Because now it's on the net, it is everywhere. And those are called bad actors or black hats. The spy, the enemy spy is a black hat. What can he do? So in cyber security and all this, there are black hat and white hat. There are good hackers, ethical hackers. They will hack into CMC's database, and then they'll come to the admin and say, hey, I can hack into your system because these are the areas where your AI is deficient or your internet security. They are doing it for a good cause. Then there are black hats who hack your data and say, give me 1 crore, otherwise I'll not let your workstation function. Those are the bad people. So when you develop, you must have white hat people. That means in medicine, if they are going to develop an AI system, we have to also work with IT experts, computer scientists, along with traditional people to see where will this AI potentially have a vulnerability. Can somebody cause some trouble with it? So before the black hat finds out, work with white hat. Now, it's not something traditionally medicine is thinking about. But if you're going to go into this world of AI, which everybody is readily jumping into without thinking, we have to be aware of that there may be people who want to use the system for bad. Regularly it happens. They say now that there are many types of war. So when war happens, for example, Ukraine-Russia war, the first thing is all the AI systems, all the electronics in Ukraine was jammed. Internet was shut down by hackers in Russia. Then they gave this SpaceX gave the what are those devices called now? Starlink, and then they were able to get around the internet. So the first war will always happen, and now it looks like an electronic and AI based. So not nothing to know that we are not going to do war in a medical institution. But if somebody wants to screw up our data set, they can easily hack and cause trouble. So we have to be aware of this problem. Next one. We need to have 100 times more workshops on AI from first year to PG to DM to faculty. What is this AI really? How is it going to interfere with our practice? How should we be more educated? So we need to have much more education on AI, right? Synergy rather than replacement. So we should, like, if you tell a worker in a factory, car factory, we like robots. Okay, so what? We train the robot. After some time, you will be kicked out, robot will replace you. But we don't want that in medicine. We want to look where AI can augment us. That's what now they say in medicine, don't stop using the word artificial intelligence. It is augmented intelligence. Hey, I'm sitting in casualty, I got a fever patient. I have 5 differential, I'm thinking that I missed something else. I put it into our system and give you 3 more differential. It's not replacing me, it's augmenting my work. So where can we use the function of the AI better than us? Or where it can help us? So I think in your talk today, journalist pretty much you're saying that half our time is spent on some paperwork, but we need more time to spend time talking to patients. So if we can have social work who will take care of the bills and other paperwork, we can spend more time doing what a doctor is supposed to do. This very time thing, or something like that you said in your talk. So think about an AI, automate much of the paperwork, automate the billing process, automate everything. Use AI to do those mundane procedures which nobody else wants to do. Because the doctor can do more of doctoring. We have to imagine to see like, okay, let the AI do that, let me do this. So where all can AI help me to do that part? Where all can I do? So doctors were spent on relationship building, getting information, counseling, management. And the AI can do all sorts of other mundane tasks. We will think in a more different way now. This is something else we must think about. Okay, people are in Javadi Hills or in some remote area. There's no access to healthcare. Can we use AI to help those people? That's why teleradiology, telepharmacy, tele all these things have become a reality. So most of the patients are going to be sitting at home. So ambulatory TP is a fantastic option. But how does that talk to the doctor here? Maybe I can have an AI system where the patient's BP check every week comes here. If it's below a cutoff, I don't need to tell the patient anything. If it's going above or below, then I flag her. So I'm using that. Or the phone search. Everybody's got a smartphone now or a smartwatch. Some of those are not really great, but I can detect systems with that to improve it. So we can see whether it can reach people who don't or not otherwise reach. So the AI should improve that part of it. Okay. Last week we heard about personalized medicine. Okay, anything on the height part of it? Any questions on the height? We are making a small parts to conclude the whole thing. Okay, height. This is finished. Now it's personalized medicine. So what is precision medicine? They will explain very nicely last time. Therapy planning, genomic, social determinants of health, clinical considerations, risk prediction, genomic. So we have AI can help in this. So increasingly when people talk about precision medicine, they think it is AI enabled or AI augmented precision medicine. So I cannot be looking at a mountain of somebody's genotypes and the socioeconomic. Actually, we're doing that now. So OPD is sitting there, we're making instant-based decision. His socioeconomic situation, family history, his genotype, and what is his previous responsibility. The doctor, the brain works full speed to make this kind of precision decision. We don't call it precision medicine, but intervals are practicing a sort of precision. Maybe the AI can augment our precision medicine. So the place where this has become hot is mostly in cancer therapies, where each individual person, genotype, blah, blah, blah. For cancer therapies, AI is starting, maybe coming into a big way. Okay, now I'm moving on to something else. Now, I think that during COVID, some of you guys had guideline development. They were doing some guidelines. There were some groups are developing guidelines. So I just want to show this exciting area in this form. How can COVID help, or how can AI help you with guideline development? Now, this is a guideline, asthma guidelines from this European Forum. It's called Allergic Rhinitis and its impact on asthma guidelines, RER guidelines. It's not important what the guideline is, but just to show you how people are thinking how I can use AI. Now, when you have a typical guideline, what happens is that a guideline doesn't answer one question. What should be the target systolic blood pressure is not a guideline. What is systolic blood pressure? What is diastolic? What is diet? What is lifestyle? What are tests? What are medicine? So a guideline will answer 10 or 15 questions. Then only it becomes a guideline. Answering a single question is just answering a 15 question. So how do you decide which question is going to a guideline? A group of experts will be called together and they say, okay, update 2024 asthma guideline update. These are the 10 important questions which people are thinking about, and we will answer them. So then same thing, we go study design, extract data, and make a guideline. Whatever. Now the thing, can we use AI to improve guideline development? So we surely can. So there's something called Google Trends. Google, we all search Google, was not search. There's one thing called Google Trends. And you can see Google Trends, what are people looking at? So when they looked at it, they said there are about 4,000 unique queries on asthma and allergic rhinitis. From that unique queries, what are people searching? That's the query. They got 37 questions. So the Google Trend led them to 37 questions which the Google Trend suggested should be answered in the guideline. 22 had not been previously posed by the Guideline Development Committee. Finally, after a lot of debate, they took two of those. Large language models. So you have large hospital data, which is just text. We are not typing text, right? This is somebody significant. But we can convert that into data by a large language model, which is recognizing text and making it into data. It looked at 22 relevant questions looking at data. 11 were not previously suggested by the panel members, and finally 4 were included in the guideline. So totally 6 of the 39 questions previously taught by the panel, which had not been taught, were added by this AI methodology. So it just tells you, I'll just show you the picture to be clearer. You have guideline panel, then you have Google Trends, and you have this chatbot looking at large volumes of health data. Each of them is trying to generate questions. Previously, we only looked at the expert developed questions. Then when you see 57 questions were suggested by the expert. This is the guideline panel. Google Trends suggested 37. And the large language model suggested 22. Then you must draw a Venn diagram. Oh, these are the Google Trends, large language model, guideline panel. Then you see how the overlap is. Then again, finally, the guideline experts only have to decide. Okay, this expert question given by Google Trend and LLMs should be included or not. And finally, they decided on a list of questions to be asked. So just to say that, hey, what are people asking? We are thinking expert, this is a question, but people are going to Google now as a first. Google is everybody's first doctor and first everything. What are those people asking? That can also tell us what questions, because those are the questions people are asking. We better answer those questions in our guidelines. So that's just the same. So what is the last part? The future. 10 years from now, and all of you guys are sitting on our chairs, maybe they should be looking after our grandchildren. What will happen 10 years from now? Okay. So this is a paper, 2035, Practice of Neurology. And it's what will happen 10 years from now. They say there will be two models of healthcare delivery. One is called a systemic model of healthcare delivery. Another one is called component model of healthcare delivery. So these are the future, at least this according to this expert. And this is a nice article. And these are some guys who are from Mayo Clinic. And they said, what do they expect in Europe? So I'm thinking that the future may also be there for us. So there's a systemic delivery model and a component delivery model. I'm going to talk about each of these in detail. We sound a bit exhaustive, but who knows, in the future when this comes, then everybody will talk about this. So A refers to patient data. This is what they have in the chart. When the postgraduate student collects it and puts it into your data sheet, it becomes information. This is just some raw data sitting in a chart. There's no value. History of diabetes. You can't use someone puts it into an Excel spreadsheet and say diabetes. So A is the patient data, B is when it becomes information. Then this patient interaction of the patient data and information is called an interaction in computer terms. When you make it into data from that. This refers to M in this model is the condition, let us say it's diabetes or hypertension in this model. M is the condition you're talking about. Then the practitioner knows about this through education. So how does a doctor know how to take care of the diabetes patient? You are trained in classes, you go online, you learn something. That is the training part of healthcare knowledge is both from the patient as well as from online classes. So care of the patient is called C. So this can affect the patient's outcomes, which is K. So these are the few computer-derived terms and information given here. So this is called a systemic AI model, which is a sort of a linear model. And in this you have a healthcare delivery, which could be primary, secondary, tertiary. You have for-profit, non-profit model, regulatory framework. We are all under the medical council or we are under the health ministry, health education, bioethics. This is how currently the model is being practiced. Okay, so The current model focuses largely on this patient and provider and the doctor's knowledge to improve healthcare. This is what we are doing. This is where we are now. So what is this new methodology? Component-driven AI changes. It's a non-linear model. It's not just going this way. The first one is B and A. Remember the patient and the knowledge. This is called the data stream. And modeling of the information which comes from here. So we don't just take this, we model this data, and that's called M. And that updating that knowledge is called K now, updating the current knowledge. Now, this could change the business model, what I talked about earlier, education framework. So this is called information, and this data stream is captured by this zone called zone 2, information technology and knowledge. This is where we are. Or this is also called the ABC cycle, where we are currently looking at. But now in healthcare, we divided this into one zone. People, places, and devices are thought of as a separate area of healthcare. And the third area is the cloud computing. Cloud, because we need all cloud to do all this knowledge. So, people, places, and devices, information technology, and software algorithms. So, these two are an extreme zones, the physical at one end and this decentralized virtual at the other end. And they are linked by this intelligence part. So people will increasingly in the future look at hospitals as three layers or healthcare and three layers. There's a physical part of the hospital, there's information and knowledge, and there's algorithm. So if you like cars, now they say there's electric architecture. It's a new thing. What is it? First, it's a software-based car. The car is more like a smartphone on wheels. Because it's more of tech. On top of the tech, you are putting some hardware, which is the wheels and the engine and whatever body, and then you're trying the human being. So that the whole philosophy of making a car is the same completely. So even healthcare also may totally turn on its head. If you look at this model. Anyway, so I've tried to summarize this. I won't go back to this again. Now, the last part. If you're interested in this AI, I found some free websites. This is from NHS UK, King's Innovation Scholars, Big Data and Skills for AI Workforce. There's a free website. You can go and learn some AI and healthcare if you're interested in this. There's a thing called Coursera. Some of you might have heard Coursera or some of the online free education tools. So this is a guy called Andrew Nick. I don't know how you pronounce it, Andrew Nick. And there's some fundamentals of deep learning for healthcare. MIT and Stanford have online courses. Just put online Stanford AI healthcare. There's an online course on YouTube. And MIT also has got that. So I've given that this is the number for the Stanford deep learning. And this is the another one websites for that. So these are some areas which one can do. Okay, I'll stop here. But I just want to wrap up. Like first week was what is AI. Then we looked at different aspects of AI and then supervised, unsupervised. Then we looked at AI in research. AI in RCT we looked separately. And now today we looked at AI in report writing, guidelines, consort AI, start AI, tripod AI, robust AI. And then finally we wrapped up with the hype. Don't get sold on that. And if you want to do an AI project, what are the 6 steps? Lastly, future guidelines. Even guideline development, you can use AI to do that. I didn't do it one thing, AI in systematic reviews. That's becoming a hot topic. It's more hype at the moment than actual substance. You're finding out we're doing some systematic review. Too much is AI. Everybody puts on top AI. It's not so great a thing. And the last one I said the future maybe healthcare may totally be, some doctors don't want to see patients anymore. Okay, why don't we move to the physical space, why don't we move to the virtual space and be a doctor? There are so many places one can be a doctor. Yeah? Okay.